So my name is Eunice Wang. I'm the chief of leukemia here at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I trained at the University of Southern California Medical School, followed by internal residency at Yale New Haven Hospital in New Haven, Connecticut. I, many years ago, did my hematology oncology fellowship and postdoctoral training at Memorial Sloan Kettering Cancer Center in New York, New York. And then I took my first job, which is my current job, as an assistant professor in the Department of Medicine in the Leukemia Service after fellowship. And I've been here for about 17 years.
That's awesome. So now can you sort of explain what genetic testing is?
Genetic testing is identifying the underlying genetic and molecular abnormalities that drive the tumor cell biology. So in addition to looking at what we call pathology and making the diagnosis of a cancer and looking at different staining of the cells under the microscope, there are some internal intricacies of the machinery of the cell that really transform a cell from being normal, healthy cell to a malignant process. And that's not visible when we see it. So genetic testing is looking at the DNA or the chromosomes that code for the genetics of the cell. And molecular testing is primarily referring to looking at mutations in genes that may cause the cell to grow out of control or spread to areas of the body that it doesn't belong in, and that may drive the speed of how fast that cancer grows and how fast it spreads throughout the body.
So why is genetic testing so critical for patients with acute myeloid leukemia, especially during the current unprecedented times?
So the importance of genetic testing is because acute myeloid leukemia is an incredibly diverse and biologically heterogeneous disease. So when they looked at doing next generation sequencing all the genes found in cancer cells, they found that every single patient that had an acute myeloid leukemia had a completely unique and individualized mutational and genetic profile. So you can't generalize. You can't say that that your patient's leukemia that you made a diagnosis for last week is the same as any other leukemia patients in your practice. So the importance of genetic testing is because of the uniqueness of the disease. The second thing, Hannah, that we know is that we have now in this current age newer, better precision medicine targeted therapy, which is outpatient, oftentimes oral pills that you can take. And these targeted therapies work better in many cases than the standard high-dose chemotherapy that requires people to be in the hospital, to lose their hair, to get diarrhea, to look like what we typically would say would be a cancer patient. However, our ability to use some of these targeted therapies is really hinged upon the identification of mutations in those cancer cells that predict for response. So for example, in this COVID era where you don't want to be coming into the hospital, you may not want to be going back and forth, wouldn't you want to know whether your cancer type and your acute myeloid leukemia could be treated with pills given in the outpatient setting? And so that's why it's important. If we don't look for those mutations, we can't use those therapies.
So for those who don't understand the process, are there really any negatives to receiving genetic testing for AML?
Well, I think there might be some perceived barriers, which I think are in this day and age aren't really, I would consider, insurmountable obstacles. One is you have to send the testing. So when you order the testing on the cancer diagnosis, on the leukemia cell diagnosis, you need to remember to order it. Then you need to maybe wait because that's not going to be instantaneous. Now, typically, and we would like to wait no more than a week. 3, 5, 7 days from when we send the sample to when we get the result. So I think it's knowing what to send. We specifically send, for example, for the presence of mutations in genes called FLT3 or IDH1 or IDH2. And then we also have to be patient. We have to say, it is worth it for us to wait a week. and to know what type of cancer we have and what type of therapeutic options we have, rather than rushing that patient into the hospital and starting a highly toxic therapy, and then 3 or 4 days later say, oh my gosh, now I have the result. And so I think it's knowing what to order, getting it back in a time frame that's reasonable, and I think also in some cases getting the insurance to approve those testing.
So what other changes have you had to implement for patients with AML as a result of the COVID-19 pandemic?
So one of the things that we've had to really emphasize to our patients that have acute myeloid leukemia is that they are all in a high-risk category. Acute myeloid leukemia is a cancer of the bloodstream, the blood cells, and all patients with acute myeloid leukemia have inherent immunodeficiencies independent of whether their white blood cell count is low or whether they're getting chemotherapy. So we do need to caution individuals about the importance of masking and social distancing, about activities that might increase or decrease their exposure. And we also need to tell them that they need to potentially be aware that their family members could also be transmitters of the disease. And even if, for example, kids are going back to school or grandchildren are starting up some activities, you know, if you're a patient with AML, you need to be a little bit more sensitive to the potential risks that you run with potential exposure for COVID. We have instituted at our institute, which is common among most hospitals and outpatient clinics, a fairly rigid screening process. We test all of our inpatients before starting chemotherapy, as well as before any elective procedures. And we try to maintain as much as possible a COVID negative environment. But certainly those are things that we need to consider. Many of my patients, in order to accommodate these increased risks, are now doing virtual appointments. And you know, I have to say, Hannah, that one of the things that's been great about, well, not great, but one of the things that has been incredibly useful that we've discovered during the COVID pandemic is how to use technology to do telemedicine. We always had the ability, we all have smartphones, we all communicate through FaceTime, but I don't think that we ever really imported that into our clinical practice until the pandemic emerged.
So looking at AML in a more general sense, what sort of research is up and coming in the field of AML that you think is worth noting?
I think that there are a couple of directions which I'm really very excited by. We know that, for example, immune-based therapies, enhancing patients' immune systems and allowing the patient's own immune cells to either become activated and target tumors has been an incredibly transformative direction forward for the solid tumor. I'm very excited by some of the immunotherapies that are being developed for leukemia, because those immunotherapies targeting or activating or infusing novel T-cell therapies has the potential to bypass all of those mutations. So it doesn't matter if you have this mutation, that mutation, that mutation. If your immune cells are activated or you infuse immune cells and they can go and target leukemia cells without the mutational, that would be, I think, a great step forward. The other thing I'm very excited by is we are identifying more and more of these mutations as we do more genetic testing, and we are developing targeted therapies. For example, there is a mutation called TP53, which is a horrible, dismal prognostic marker that we identified about 10 or 15% of AML patients, and we now have targeted therapies to target that very, very bad mutation. So I think targeting the immune system and looking at novel small molecular targeted agents represents the way forward for us.
So where do you see AML treatment going in the next 5 years?
I see AML therapy moving towards a highly targeted, highly specific and/or immune-based therapy. And frankly, Hannah, I see it moving more and more into the outpatient setting. I see us doing these genetic and personalized molecular panel at diagnosis, at recurrence. I see us doing incredibly specialized, highly sensitive and specific assays to detect minimal residual disease. And I see us moving into a future where we can import all of that genetic molecular information potentially into an algorithm, spit out targeted therapies, maybe combinations of targeted therapies. Many leukemia patients have cancer cells that express more than one mutation, either at diagnosis or relapse over the course. So I kind of see like this very highly personalized, highly targeted, largely ambulatory treatment paradigm moving forward with sort of a cocktail of can you combine an antibody with a targeted therapy and maybe a little bit of chemo. So I'm really excited. The field has become completely different from when I started 17 years ago. We've gone from having a standard chemotherapy regimens to having 9 drugs approved in the last 3 years. So it's actually a little bit of a whirlwind.
So that's all I had for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
No, I think you did a great job of mentioning all of the things that are the key issues that we're dealing with right now, and particularly in this era of COVID.
Great. Well, thank you so much for taking the time to speak with me. I really do appreciate it.